All right, good afternoon. We're back again today with another session in our series on best practices in substance use treatment. We're beginning this journey with 5 digital workshops, but we'll continue to add to these in the upcoming months. We know that you're aware that there's a lot to running a successful treatment program, and we can't stress enough how important it is to have a consistent philosophy for treatment so you can send a consistent message to your clients. This is really the catalyst for our taping of these workshops. We recommend watching these sessions with your staff or minimally holding discussions on these topics. Mindsets like how you and your team of professionals view addiction or what type of therapies to use in your facility have to be similar so that patients get a unified treatment program regardless of which therapist, family coordinator, or other staff member a patient comes in contact with. My name is Catherine Hentrick, and I'm a case manager at Addiction Treatment Strategies, ATS, and we're located in Edwardsville, Illinois, just outside of St. Louis. Addiction Treatment Strategies is a 6-month intensive outpatient treatment program. We are a therapeutically based, medically assisted substance use disorder program, which provides an extremely effective treatment program. This session is going to be led by the founder of Addiction Treatment Strategies, John Crum. And John, for our viewers, I know we do this at each one of our workshops, but can you talk a little bit about how the Southern Illinois Health Foundation has been involved in this process?
Certainly, SIHF SIF saw the need in the rural communities to provide education and treatment facilities for patients in the rural communities, and applied to our core Rural Communities Opiate Response Program and received a grant to help in really adjunct to staffings and other clinical programs. And this component, the staff training, is one of the things that was included in the ARC process.
Okay, perfect. So today, John, we're going to talk a little bit about probably one of the most important or an immensely important portion of a treatment program, and that is the family component. So today's workshop is going to be called The Full Family Experience, Curing, Recovering, and Managing Addiction. So John, why are you calling this presentation The Full Family Experience?
Well, I think everybody, you can't treat a patient by themselves, in terms of it takes a whole family to get involved, whether it's voluntary or involuntarily. They're included in the process, so they need to be educated and informed. I think once they get enmeshed in the process, the outcomes are significantly better. So people need to be better informed, better educated, and better care.
Okay, so I know that we talk about, and I think in order to understand how families have such an active role, in someone's success in any type of a treatment program, we have to understand the process of the disease. So, in order to provide a competent treatment, of any disease, there has to be an understanding of the impact and then also that causative factors of the manifestation of that disease. So what we accept here at ATS to be true is that addiction is a chronic relapsing disease. And consequently, a prudent clinician will proceed from the understanding of the definition and accept varying degrees of change from the active process of full-time consumption of a drug or alcohol. John, what do you see as the most complicated aspect of goal-setting process in the treatment of addictions?
Well, I think you said it probably in the first statement, where people don't really grasp the concept of what a chronic relapsing disease means. Probably the most complicated process of that is that people don't believe that they can abstain forever from the very behavior that constitutes the definition of what an addiction is. That is the chronic relapsing disease part. Chances are, if someone could quit easily and never touch alcohol, go back again, they probably didn't have an addiction in the first place. They may have simply been over drinking and drinking too much, but never really developed the neuronal changes for an addiction that would include those diagnostic criteria that you mentioned, along with a compulsion to drink, the cravings, and the continued drinking in spite of the consequences. I believe the most important thing that we can do in the beginning is set goals that can actually be achieved. That decreases the frustration and increases the probability that people will continue to try and get better. That means elementary goals in the beginning, and in getting other people involved in the treatment process simply by completing maybe thought logs or journaling, such that the patient can begin to see that they have patterns and they know what they're doing. Obviously, with the CBT concept that we've discussed previously, the strategies we are teaching, supporting, and for the first 6 months, we want people to make small changes. So in the beginning, we encourage and motivate people by decreasing the guilt and remorse that comes with the initial stages of treatment. This is education in addition to components of motivational interviewing. We keep increasing, if you will, or raising the clinical bar where we expect more from patients as they get better so that they can complete more tasks, become more stable. And in reality, the treatment process involves taking risks in conjunction with your treatment person to get better. And I think this always involves the nature of how the patient is getting better in relationship to the family dynamics. And I think that's the real key in the beginning of treatment setting.
Sure. So only with an understanding and acceptance of the definition can one fully realize and establish acceptable goals and outcomes of the treatment process, kind of like the goals that you talk about setting there, John. So implications are that there will be stable times and perhaps some unstable times in the person's process of learning to manage their medical condition. And we know that because of the definition of addiction in itself, that's just a reality. So John, does that mean that if you accept and recognize someone's addiction, this then gives you permission to drink again because it's just inevitable?
I think the people on the outside in the beginning would probably believe that to be true. And obviously, that's a rationalization for why people drink. You can certainly tell in the initial stages that when people are unable to understand what's happening, which is potentially could be a component of denial, they don't understand the concept of a relapsing disease. That relapse may take place in a day, a week, a month, 6 months. As people get better, it may be much as a year, 2 years, or 3 years. So that's a component of education in the beginning, and I think a heavy emphasis on the education, not only the patient, but it's the family, so that they understand and decrease some of their judgmental processes.
Yeah, and I think that's what we have here in this next slide. All of these changes have an impact on those closest to the identified patient, the manifest symptoms of the disease. That's the family, that's employers, it's parents, it's grandparents, it's neighborhoods as well. So if addiction thrives in isolation, recovery must thrive, in community. So people are relational beings. That's just human nature, and they require the company and support of others in order to survive. So whether it's a family of origin or the family that's created, these loved ones are often our most intimate relationships. So John, how have you seen addiction thrive in isolation, and why does it thrive so much in isolation?
I think addiction is an extremely secretive process. Most people don't want to be discovered or identified. That's why they continue to hide their drinking or using by themselves, because they feel that they might have to change a behavior if they were discovered. No one wants to really give up on a habit that they feel like is working for them. Remember, we're talking about positive reinforcement at the very basis of human behavior. That's what an addiction does to the brain. And we're not talking about the cognitive awareness or a particular behavior that's damaging on multiple levels on multiple fronts. People don't realize that when they have an addiction. I've never met the person who knowingly, willingly said, I think I'll go out and do something and get addicted to it. That simply doesn't happen. It's a far more complicated process than that. It's obvious, and when we start dealing with even the obesity epidemic, it's a significant addictive behavior, and everyone knows the medical side and the effects of what's going on to their body when they become addicted to food substances and get obese. Yet that doesn't mean that the person can simply change that process overnight. So I think coming to grips with the concept that a person needs help makes them very vulnerable and exposed, especially in the beginning, and they feel like they're weak. Obviously, this is associated with the stigma that comes with any type of addictive behavior. The shame and the guilt that keep people from seeking any form of mental health treatment is extremely common in what we're dealing with. So I think the initial steps involve at least acknowledging that others must be involved in the helping process. And then this then becomes the community of everyone that supports the person who has addiction. And it certainly is essential in people getting better.
John, when you said the person needs help makes them vulnerable and exposed to being seen as weak, I think we see that with family members as well. They feel like they've failed as parents. They failed as a wife. They failed as siblings, not being as supportive as they should have been. And again, that's not the truth by any means, but it's definitely a feeling and something that we hear quite often with our families.
Well, I think that's something that we deal with in educating families of the person who has an addiction, and we certainly use the cognitive behavior therapy approach there in terms of their distorted perceptions involve their feelings that somehow or another they had done something to perpetuate this addiction. In reality, the family at that point needs the education so that they understand their role in bringing about the change for the patient as well as the family.
All right, so this one here, this is kind of a gimme, since this is a presentation on the full family experience. But viewers, true or false? Addiction is only dangerous for the one with a substance use disorder. So, in the very worst moments of addiction, the very worst times, those overdoses, suicide attempts, relapses, the one in active addiction is typically numb, but the family is sober. So not only do they have to watch someone they love turn into someone that they don't know, but they also have to watch and turn into someone that they might fear, as well. So, John, can you speak to that?
Yeah, I think what you're hitting on here, Kathy, is that statement may be true according to conventional wisdom. And what that means is oftentimes conventional wisdom believes that to be true, but in reality, that's a false statement. Addiction is extremely complicated, and it certainly involves family members. So if you have someone in your family with an addiction, especially to opiates, you know that you live in a constant state of fear. The state of tension does not allow the family to function normally at any one point. There's a state of tension that permeates all family dynamics. Full-time uncertainty and a total lack of trust and predictability as to what's going to come next makes the family at risk. In addition, because they can't read what's going on, they certainly can't control what's going on in their addicted family member.
Yeah. So why is addiction a family disease, or why is it considered one? Addiction is often referred to as a family disease because it can impact the entire family system. When one family member struggles with addiction, it'll create a ripple effect that touches every aspect of the family dynamics and relationships. What is this impact and how does it affect each family member, John, from parents, siblings, aunts, uncles, even employers?
Well, I think the hard thing to do with addiction is what I call the elephant in the room. It's certainly applicable to families with an addiction. Everybody's afraid to talk about what's obvious. I mean, people have been hurt. People are uncertain as to what's going to happen next, but we can't bring anything up for fear that if the person with addiction is angry, they may strike back. So everyone fears bringing up the obvious and difficulty in confronting the issue with it that the person has, because generally that relates in some form of a heated argument or some type of discussion. People run out of the room mad and angry, and nobody wants to stir up the hornet's nest. So I think that's the family dynamics have certainly been impacted, probably the most significantly, other than obviously it affects people who go to work and everything else. But I think the family is the one who suffers the most.
I hear families so often say, I had this boundary and I had this line of what I thought was right and wrong, or what I would allow and what I wouldn't allow in my home. And through addiction and that family's ability to not function any longer in a healthy manner, that line starts to move, and that line starts to move a little bit more. And that whole family dynamic shifts and changes along with that change in boundary. I see that quite often with our families.
I think that happens all the time in terms of, we refer to that as a mission creep, so to speak, if you will. What we thought our boundaries were, because we've become a little bit more tolerant of behavior, because we maybe become a little more educated, then our boundaries exceed those things that I thought that I would never do. I found myself doing those things that I didn't believe to be true are now true. And so once you're enmeshed in the process, the component of what you were formerly unable to tolerate now becomes simple to understand, mainly because my understanding has gotten better, as well as my sense of hope has indeed improved. It just gets dangerous when our boundaries become extremely muffled and not exactly sure what's going on.
Mm-hmm. So there are really two reasons, of many, for why addiction is considered a family disease. One is the genetic factors. Addiction can have a genetic component, meaning that individuals may be more likely to develop an addiction if there is a family history of substance use or addiction. And then it's also called family disease because of the impact on relationships. Addiction can create conflict and disharmony in family relationships, leading to breakdowns in communications, trust, intimacy, excuse me. Can you help us all better understand that genetic factor? I think we understand the impact on the relationship side, John, and we'll talk about that a little bit more, but give us a little science lesson on the genetic factors.
Well, if it was genetic and there was one gene that caused the problem, we would have fixed it a long time ago. There is no one gene, even for simple addiction to alcohol. We've already identified at least 8 in the dynamic relationship between those genetic factors or markers. And all that really means is that someone has a predisposition, even though it's genetically inherited, up to maybe 40 to 60% of that is genetically inherited. That doesn't necessarily mean that gene is going to be activated. So that's the epigenetic factors in terms of the role that if you observe your parents drinking when you're growing up, that's an epigenetic factor that says that this behavior is acceptable to me. So it's not a problem if I drink and smoke. That would be true. If it's accepted in the behavior in the family, and parenting style plays a part, compliance with rules and regulations, structure, accountability, learn coping mechanisms, all those things are observed directly and indirectly in family dynamics. Birth order, in fact, does play a role in genetics in terms of manifestations of addiction processes, especially if you're the older brother and older sister uses substances. It increases the probability that later borns are going to have that problem, not necessarily because of genetic factors, but epigenetic factors. So it's a combination of genes plus learned behavior, if you will.
So there's a couple of other reasons why people call addiction a family disease. One is the emotional toll that it takes. Loved ones of someone struggling with addiction may experience various mental health issues like stress, anxiety, depression, because of unrelenting uncertainty, insecurity, and sometimes even hostility. Addiction distorts the life of everyone it touches, exploiting their emotions and squashing their hopes repeatedly. So what we don't want people to think is that a substance use disorder cannot be managed, because we know that it can. But during active addiction, it can do all of the things that we've just mentioned in this slide. John, talk about that just a little for us.
Sure. I believe there's currently a split in a number of philosophical approaches to addictions. Currently, the goal is sobriety, and if you fall short of that goal, that somehow or another you're a failure, or at least you feel that way. I think that's a good place to start. But in reality, the most important way to treat someone with addiction, in my opinion, is to learn to manage the addiction. It's like managing all other types of chronic diseases, which would include diabetes, hypertension, COPD. Yet I believe we've got a long way to go before managing an addiction becomes an accepted goal, even from an elementary, if you will, harm reduction model. I think that's a great goal to start with. I think the evolution of treatment is so complicated, and we move so slowly. Even though we have research that points to this, and this, we know from the time that a particular research study has been printed in a journal, it probably takes close to 17 years before that evidence is then supported by people implementing those strategies in clinical practice. I think that's a problem.
Yeah. So this, these couple ones here just seem very obvious, but I think they're definitely worth stating. Addiction is seen as a family disease because of the financial burden that it brings to families quite often. Addiction often comes with financial strain as money's diverted from other family needs to support the addiction. And then the behavioral and emotional problems in children. Children of those struggling with addiction may develop behavioral or emotional problems due to the instability caused by the addiction and the instability within that family. So, John, I know you've seen families who've used their entire life savings and their retirement accounts. I hear that quite often, the frustration, from our families. Say, this is not where I thought that I would be right now. I'm 65, I'm getting ready to retire, and, I have an adult child in my home, for example. And they spend this money, trying to get a family member, the help that they need. What is the cost of a typical 30-day rehab facility, and what are the statistics on outcomes for those facilities?
Wow. That's a complicated problem in our culture right now. The cost of rehab varies. It's probably, if you will, one of the most unregulated businesses in the country. It depends on what the rehab facility is offering. I mean, you can get anything from room and board to helicopter therapy and equine therapy, which means you get to ride in a helicopter and ride a horse on a beach. So it depends on what the rehab facility is offering. It can be as little as $18,000 to $20,000 for a 30-day stay, upwards of $100,000 for a 30-day stay. Now that's a lot of money. Think about that. You have to not decide why someone needs to go to rehab. Well, there are lots of reasons to go to rehab. Well, the most common reason in reality that people attend rehab right now is because they need a place to go. Someone's kicking them out because they got frustrated, they got upset about something, and it's safer for them to go somewhere. They also may need detoxing with medical supervision. Obviously, that should be in a safe environment. They may also need some form of stabilization. And when they become somewhat more mentally stable, some type of clinical intervention to help them learn more coping strategies and prepare them for discharge. This means they need a safe place to go to follow up. Now we're talking anything from 18 to 20,000 to upwards of really 100,000, 150,000 for 30 days. And everyone's looking for a fix. There isn't a fix that will bring an end to their addiction. So we need a continuum of care that may start with outpatient and then go to rehab, and then with follow-up, probably in safe housing if they can't go back home, if that's not an option. And then you have to look at ways that you can move, if you will, people moving in and out of treatment, and make sure that we have a continuum of care that they can be accessed on a regular basis depending on what their unique needs are.
No,
So it's extremely
yeah,
expensive.
I hear you talk about that continuum, a lot of people moving in and out based on the depth and the need, of the patient. And our families so often, John, I know they think that, okay, I'm making this financial promise to send my child, for example, to a 30-day, or my husband or my wife to a 30-day rehab facility. And so I think because of lack of understanding and lack of information out there for our families, they kind of hang their hat on that, and they're like, okay,
Yes.
once I spend this money, we're done with this. It's over, and this, my husband, my wife, my child should be fixed. I know that you see that a lot as well, and a lot of frustration that comes from our families, when they come out of that, just because of that lack of understanding.
Well, it's not atypical at all, Kathy. As you know, for somebody to go to rehab and within 30 days they're already using again. I think the most detrimental impact of that is on the family. I mean, the person is in the addiction and may have a little empathy for what's going on or a little understanding what's going on for them. But I think the disappointment that's manifested in the family and the resentment that comes from that, because they had their hopes, if you will, predicated on how much money I spent, which is why people spend more money. If I spend more money, that gives me a sense of hope that they're going to get better and stay better. That's the difficult part for the family to adjust to.
Yeah. So it's also called a family disease because of an increased risk of abuse. Substance use can increase the risk of physical, emotional, and sexual abuse in relationships. And there's a higher chance that family members may experience abuse at the hands of someone in active addiction. And sometimes our families don't understand this, or our families do, but maybe sometimes community members don't. Why does drinking, or using in private turn to violence sometimes?
Well, I think most people know individuals who drink too much and they're a happy drunk. Those are the people that are easier to get along with, even though physically it may be causing the same problems to someone, but it doesn't have the same negative impacts on families. It's the angry drunks. Some people's genetic predisposition to their body doesn't metabolize alcoholism well. It manifests itself in anger. They become very, very physically aggressive. It's like anything else. If you want to fight, go enter a bar and get drunk, and then you can start a fight with just about anybody in there. And I think that's the nature of an angry drunk person. I think alcohol distorts one's perception of what's actually happening in a real relationship. So angry drinkers have a tendency to attack anything and anyone that threatens their path of continuing to drink. I think
Mhm.
that's significant. And if a spouse comes home, if you will, from a bar drunk or drinking, the last thing you probably want to do is have some type of a confrontation at that point. Get out of the way until things stabilize. But I think that's the real danger when if someone is indeed an angry drunk, just about anyone can be a potential target.
So the impact of addiction on the family is huge. You know, when one person in a family is struggling, it's exacerbated by unconscious family dynamics that are at play. In order to help that one person, we need to reach further into the whole family system. We must teach families the changes that the entire family may need to make for long lasting health and wellness to occur. You know, we've seen so many times when families you struggle even as their loved ones begin to heal. You know, they've been so immersed in the care of their loved one that it's uncomfortable for them to be in a position where that person may need them less. You know, they're even lost at times. You know, so families need our support all as we talk about continuums, all along that continuum when they're in the throes of active addiction and as they heal and get better, because that dynamic shifts and that dynamic changes. So, John, when you see families that are kind of in that situation where you know those dynamics are shifting, those dynamics are changing, you know, as we move from feeling like things are healing and they're people becoming more stable to unstable to healing and unstable again, you know, and talk a little bit about why that's so hard for our families.
Well, I think you have to use the psychological concept of ego. Everyone has an ego. That means that at some point they have the potential to be hurt. And what's happening in an addiction process is that the family members have been hurt and disappointed during the entire process of addiction. If everyone in the family would could be, if you will, a therapist and react neutrally, everything would be fine. But that's totally unreasonable because
Yep.
everyone has a vested interest in what's going on, and the feelings of being hurt, lack of trust, being disappointed time and time again. The family values have been violated. So I think you're living in a maelstrom of psychological problems, and people living in that are really really uncomfortable full time. So it's really difficult not to get trapped in the cycle of appearing someone is almost cured because they've been stable for 3 days or 5 days, and then you get disappointed because they drank again. That kind of the other shoe drops, and then they have to start all over again. So family members get hurt repeatedly, and you can't be immune to that pain. And I think that's why people specifically with addictions, family members need to be involved in treatment for their own mental health. I
Mhm.
think that's the part that people shy away from. That's the person who has the addiction. They're the ones that's the problem. They have the problem. Yeah, but I guarantee you that the family is reeling from the havoc that's being created by the lack of trust and the continued disappointment. So I think
Agreed.
family dynamics for family mental health and addiction is extremely important.
Yeah, I know it. I bet it's at least once a week that I hear from our families, from one family member or another. I'm just waiting for the other shoe to fall. You know,
Mhm.
I cannot be pleased right now because I've been happy, I've been ecstatic, I've been excited for growth, and then the shoe falls off, and so they kind of hold themselves, you know, at that place of I just can't go there. I can't be excited yet. You know, I'm just waiting for you know the next crisis to occur, and that's a very sensitive place for our families to be. So, what healthy a family works is a balanced ecosystem with secure connections and well established boundaries. So, if one member is unhealthy, the entire ecosystem is thrown off balance. And by a balanced ecosystem, John, do you mean that everyone has a familial role?
Yes, absolutely. In terms of whether you're voluntarily involved or involuntarily involved, if you're in the family, if you're a sibling, the impact of what's happening with a brother or sister has an impact on you. It has an impact at the dinner table. It has an impact on
Mhm.
mom and dad's well-being. Um, Now, if we could, one of the goals of family therapy obviously is to teach the family how to respond in a family crisis. So we teach them coping skills and being supportive of one another because everyone's hurting. So it's not just the identified patient who's hurting. It's the byproduct of the impact on the rest of the family. I think the operative word in what you're saying is here. I think if a patient has an addiction, the entire family struggles. I think it's a continual, ongoing process from which we have all kinds of systemic byproducts of anxiety, depression, ADHD, for sure. Trauma is created by families that are impacted by this.
That unbalanced ecosystem force other family members to adopt unhealthy coping mechanisms as they try to get back to some type of equilibrium. This often leads to blurring of boundaries and codependency. And the impacts addiction has on that family unit are complex and varied. Sometimes families adopt unhealthy coping mechanisms and they're not even aware of it. Sometimes what they're trying to do to help or to just keep their family member alive causes them to blur those boundaries or allow things to happen at home that they never thought that they would allow before. And kind of like what we talked about a few minutes ago, here was my line, and now that line has moved and my boundaries have blurred. And I know in the most extreme cases, John, I know that you've seen mothers actually say that they're going to walk away from their children, which is typically what we consider the strongest bond possible, because they just can't cope anymore. Is that always considered an unhealthy coping mechanism?
No, I don't think so. Now, when you say someone's walking away, I'm thinking there's someone else to provide care for this child, not just necessarily abandoning the child. Walking away because they know they're putting their child at risk is a good coping mechanism, as long as there's a backup plan. But this versus continuously putting your child at risk because of your substance use would be a healthy mechanism. This may be one of those reaching rock bottom moments when you as a mother realize that you're out of control and need to get some type of help, and you need to put your child or your children in safety. So I see that as a healthy coping mechanism.
Yeah, I know we hear a lot of community members say, you can't just do that. You can't just walk away. You can't just walk away. But there's times when you have to put this scenario in the hands of someone who is healthier to be able to handle the situation, or just to give you some sort of a mental break. So the impact of addiction on the family, the National Institute of Health published a study on the emotional and behavioral effects that substance abuse has on family systems, including unmet developmental needs, impaired emotional attachment, financial hardship, emotional distress, and abuse. This study showed that everyone in the family is affected by addiction, even if just one person is experiencing it personally. So here, and most of our therapists are extremely well aware of this, but families differ in structure and makeup and number. They have their own rules, they have their own values, and cultural factors and multi-generational patterns have strong influences on families. So family therapists need to take that into account and must be aware and sensitive to all of those different family structures in order to have success with working with families as well. So we talk about professional treatment in this slide. Family can play an important role in recovery from addiction. While professional treatment is essential for successful recovery, family members can provide a greater sense of security and understanding that can help to strengthen resolve during difficult times. So John, talk a little bit about the professional treatment necessary for families.
Oh, I think it's absolutely necessary, in my opinion. First, we start with family education so that everyone knows what we're dealing with in regards to the addiction process. The identified patient doesn't necessarily willingly or unwillingly do things to offend and hurt other people, which is what family members feel like. That doesn't change how we feel about what they do to hurt us, but at the same time, it helps the family understand the dynamics of what's going on in addiction. With family therapy, you can work through some of these feelings of disappointment and mistrust so that everyone can be a component of helping. The fact that you can communicate is extremely important when we go through the dynamics of what's happening. It's not unusual for family members to at least initially say, it's not my problem, you go fix yourself and don't include me. I think that's extremely common with the people we work with. This is a component of denial on the part of the family, and they're most likely unaware of the impact that addiction is having on them. Even though they may be having a hard time sleeping or something like that, they're totally unaware that this is as a result of the chaos that's going on in the family. Um, Everyone has their emotional limits, and tolerance varies. That's why I think people need to be assessed and treated through the entire process. The family therapy model, really, the intent is to involve everyone in the treatment process so that the dynamics between all the people improve. It's not just the identified patient. That may be the one who's bringing the problem to the table, but I guarantee you it's a family problem.
And so there are a lot of things that families can do to be supportive, and their roles there in the addiction recovery process. One is accountability, connectedness, emotional support. They can provide a lot of emotional support, probably more than anyone else can because of those bonds. Practical assistance, and then by encouraging healthy habits. So, Jen, what does accountability, for example, look like when we talk about family roles?
Well, I think one of the main things that's happened is a lack of trust, or trust has been violated. So accountability means doing what you say you're going to do at the time that you say you're doing it, so that people can begin to see that you're actually trying to do something. If it's a simple task, did you do it when you were supposed to do it? Did you take out the garbage without being told? All those types of things go to the point of accountability, which then makes the family members believe that you're actually trying to do something. And it may or may not specifically be related to whether you drank or you didn't drink. It's whether did you do what you were told to do when you were told to do it. I think that's the accountability concept.
And then, so how do we ask family members to help us in holding our clients accountable?
Well, I think it has to go back to what we were talking about earlier, Kathy. It has to be simple tasks. Did you do what you said you were going to? Did you pick up your room? Did you make your bed? Those types of things, because for the most part, when the patient is struggling, they're in a daze. They may or may not be able to do. They may not even be sleeping. So to do those tasks that we take for granted, even activities of daily living. Did you brush your teeth? Did you wash your hair? Did you take a bath? All those things help in indicating that a person's getting better, and they may need a lot of prompting in the beginning. That's accountability.
Yeah, and I know you do a fantastic job when you're working with our clients to help them understand that that's not nagging. That's having family members hold you accountable so that you can get healthy. And because at the very beginnings, that's exactly what they're thinking. They're just nagging at me. They won't leave me alone. All I want to do is just stay in my room. And so that they can get extremely angry about that. But I think I've seen you do a fantastic job of working with clients and saying, no, that's not what your mom is doing. No, that's not what your wife is doing. She's holding you accountable to the kinds of things that you need to do in order to be healthy and stable.
Well, I think that's a normal part of the process in terms of what you're talking about. I'm certainly the patient feels like mom's nagging, but mom was probably nagging long before you had the addiction anyhow. So mom was just reinforcing the fact that you're not doing what you were told to do. And now that you have an addiction, you're even less accountable than you were before. So you've got to be a little more accountable to the processes so that everyone feels like you're getting better. So just because I feel like it's nagging doesn't mean that it's nagging.
Yeah. So families can help create a positive environment for recovery. There's lots of ways to do that, but some of those are learning more about addiction and what someone in active addiction is experiencing. And we've talked about that in a number of our workshops, how important it is for everyone to understand that addiction is a medical diagnosis. Accepting that the family member needs support, including professional treatment, and taking steps to recognize and change enabling and codependent behaviors. Anything else you want to add to that, John?
Well, I think it's hard for family members to understand what treatment means. I think they're thinking that some magical person is going to probe into the inner recesses of the brain, and it's very threatening to think that really what we're talking about is improving communication skills. If they saw it as improving communication skills, which is the core of treatment anyhow, they would be more willing to engage. Yeah, I'll help out if I can learn to talk to my son or my daughter, my wife, or whatever. And that's really what treatment is all about. It's improving communication skills. It's nothing that's somebody's going to do something that's all that threatening. No one wants to be discovered and see that they've got some bunch of skeletons hanging in their closet. And I think that's why people stay away from mental health treatment facilities in the first place, that it's a very fearful process.
So a couple other things that families can do to help create a positive environment for recovery, avoiding drugs or alcohol in their home, creating a safe, sober environment, and encouraging the family member to keep up with ongoing treatment. So some of the goals of family therapy are to facilitate and improve communication, like John just mentioned, shift and change in flexible roles and rules, model, educate, and dispel myths around addiction, strengthen the family system, and improve home environment. And John, at the beginning, when should a family member meet with a therapist?
Day one.
Okay.
In terms of, that's what we do here. We involve the family members, and one of the hardest things that people or fail to understand with regards to all the over concern for HIPAA violations, regulations. I can't tell you what's going on, or I can't tell you what's going on with the treatment of your child. I said, no, you're involved with the treatment of your child, and I'm going to have a release so that you can communicate with me, and so that you can communicate with that child, if you will, so that we're all on the same page. So I think that goes a long way to dispelling the myths that this is going to be secretive. It's not that if an individual patient has something that's of a clinical nature that doesn't need to be discussed with their family, that's certainly something that the therapist has to be bright enough to say, no, we're not going to discuss that with your mom and dad, or whatever it is. But we're certainly going to discuss your response to treatment, your willingness to engage in treatment, and some things that they can do to help you get better. And for the most part, for the first 3 to 6 months, it's most likely against the patient's will anyhow, because they're already combating the fact that they have to give up on the positive reward that they're receiving from that medication or their drug that they're taking, and they don't know what's going to happen next. So that fear and that struggle, I don't know if I can give it up on this, because there are withdrawal symptoms for almost everything that we have anyhow. So they're going to be uncomfortable for a while, and they need to be able to talk about that in a safe environment, and that's usually with their parents or their family members.
And I know you said initially day one, of course, but in what other situations would you recommend families to call the therapist and ask if they can come in and see them?
Well, if there's something that's going on at home, if they see that a person has increased the risk in terms of their engaging in more dangerous behaviors, we may need to change the level of care in terms of they may not, if they're hiding drugs or doing something like that, then they're probably not a suitable candidate at that point for outpatient treatment. They may need to go to residential treatment. They need to go to detox. So the family members may be the first ones that can identify a change in a pattern of behavior at home that you don't see, or that the patient doesn't admit while they're in treatment. So I think family members are extremely important liaison members of the treatment process.
So there are also some dysfunctional roles that family members play. And I know I heard a family member once mention to me that, they felt kind of like their family was like a mobile over the baby's crib. As soon as the client or the patient, started to drop, it felt like everybody else was kind of thrown off, like, kind of like when a baby pulls at that mobile, one of those stuffed animals on there, everybody else gets jostled and everybody else, kind of moves along with it. And what that does is it creates sometimes some very dysfunctional roles, that family members begin to play. One is codependency, and then another is absolute enmeshment. And it's really easy for these unhealthy relationship dynamics and coping strategies to become normalized, within a family, where they don't even begin to realize that that things have changed. And I know you call that kind of a mission creep, John, but how do you see codependency and enmeshment in some of our families?
I think that's a very complicated process in terms of codependency. Is one of the many issues with codependency is that it allows the person with a substance use disorder to not feel the consequences, like pick up the barbells themselves, have somebody else do it for you. So codependency is an unhealthy dynamic that manifests itself as impact on the physical level, the emotional level, the cognitive level, and then the relationship and spiritual example, like a parallel process. A client is out all hours of the night. The parent mirrors that behavior, and he stays up all night and tracks their phone, doesn't sleep until the client is at home. That's codependency. Whatever's happening to the client is being felt by the parents or the person who's trying to get them better. That's an extremely detrimental process to the person. Generally, it's a parent or a spouse that's codependent on the behavior. So while the identified patient gets the benefits of the substance abuse, the one who pays the punishment for it, if you will, is the person who's trying to get them better. I think the second the process, enmeshment, they have difficult time functioning without the other person. The parents, for the most part, hopefully, we're hardwired to help our kids. Helping them that can then turn into hindering them by detaching with love or separating the person from the disease is what we still have to be able to do. This is the person. This is my child. This is my spouse. I'm going to love them regardless of whatever's happening, but I'm also going to take care of them in spite of the behaviors that they're manifesting. So I love the person and I dislike the behaviors, and that's what I call mission creep. While our intended structure and planning was to be as slowly moved our limits, we've slowly moved our limits away from what we thought and how we would do things. We actually engage in behaviors that are harmful to the identified patient. While we thought we were helping, as we get enmeshed, we end up hurting the patient because we have changed the boundaries and we're tolerating more and more unacceptable behavior.
Okay. So let's talk about this kind of bit of homeostasis, that disequilibrium, and things that families begin to feel. The concept of homeostasis, which helps to explain it. This means that a family unit tends to establish equilibrium in response to changes. So whether a change is positive or negative, the family adjusts to a new normal. And I think that's kind of what you're talking about there, John, in our last slide. In terms of addiction, habits that are not healthy become ingrained as the group settles into equilibrium.
Well, it's more akin to if juggling. It's how many different roles can you play at the same time and still be stable? That's really, really hard because what was normal, predictable, almost on a linear line is now not so longer linear. It's everything is in somewhat chaos. Everyone's role is changing. What the identified patient gets in trouble, everybody's role changes again. So it's a very family dynamics are very fluid and they're not static. So what we were when we were younger is not what we are now. Things change. We have to adjust to this extremely chaotic situation that's brought to the family by the IP, and that the family has to address it at some time. And what we do for the most part is repress all this information, and then it bubbles up somewhere. I think this gets back to the importance of education and reinforcing any type of positive change in the part of the family. That's a component of motivational interviewing. I think it's really important that you focus on the family and say that no one's going to be cured. What we're doing is learning to manage this stuff. And I think the most important part, even in that treatment process, is to teach families to be patient. We're not talking 30 days, maybe we're talking 18 months to 24 months to get people somewhat stable.
Mm-hmm. So, John, there's a lot of talk about codependency, and I think we will probably end up doing a workshop completely on codependency because it's a topic of its own. But how and why does a helping relationship become a codependent relationship?
Well, real or perceived abandonment or the inability to develop appropriate attachments to a reliable caregiver is really what we're talking about here. Helping, by and large, is supportive. It's guiding. It's logical. It's a leadership role. So, in codependency, what we have is excessive emotional or psychological reliance on a partner, whoever that is. This is usually the one with the addiction. So, this is when a role of a caregiver loses objectivity and will do anything to help the identified patient, which includes purchasing substance for that person, giving them money, taking them to get substances, or just about anything will eliminate the fears that the codependent person has on the identified patient. Will go almost anywhere to make sure that the patient's okay and not uncomfortable. And I think that's a dangerous process to engage in.
I think that's kind of what we were talking about.
Right.
Line moves, and it's like, where am I? I didn't think that this is where we would ever be in our lives. Some other codependency behaviors: needy, clingy, submissive. Trying to control others to feel secure in their relationships. So I hear from families a lot statements like, I don't have the problem, so why do I need to spend all of this time in sessions and therapy and coming to these family therapy groups, or why do I have to attend these sessions? What would you say to this parent, this wife, or this sibling?
Well, I think probably given that we're dealing with an opiate epidemic that's killing 115 to 120,000 people a year, whatever it is that we have been doing isn't working particularly well. And I think the part that's not working particularly well is that we need to get family members involved at an earlier time. So I think we have to shift the focus from focusing on the person as a singular person that needs to in recovery to hold the whole family members need to get better as a family unit. Definitely to save the life of the identified patient, that's for sure, because addiction by and large is an extremely insidious disease process that affects everyone that's in the family. So I think the person who's in an active addiction is just a component in the family, and it's impacting on the loved ones. Those are the people who need to be providing the community support for the identified patient. Those are the ones that have to understand that there's going to be a lot of ups and downs through this process. They have to stay the course. They need to get involved in reality. They need to get involved in the family therapy approach process with addiction. I think this is critical.
So what does that first typical family therapy session look like for someone who's never been involved in one before?
Well, hopefully the therapist will explain to them what their role is. Patients bring communication of behavior problems to the session. The therapist can talk and listen to the family interacts. He points out what's going on in the family dynamics. He tells them who's playing what role and how they can better communicate. So he basically sets the stage for a particular problem. They may bring a problem that's been going on in the house, and then he shows people how they communicate, and then has an active process in teaching them to communicate better. Usually it's going through the CBT process, cognitive behavior therapy process, so that it's not quite so emotional. It's more of a teaching, education, family therapy process. So you have to accept the problem. First, you define the problem, then you kind of create some type of goals. This is what we're trying to do, which is some level of reformation of what's happening, and then acceptance that we all agree that this is indeed the problem, and this is what we need to do to address that, and that takes place in family therapy.
And wouldn't it be nice if, every family said, I'm all in, and I am ready to do whatever is needed, to help my loved one heal. But again, like you've mentioned, people bring a lot of history, they bring a lot of hurt to the table, and that's not always the case. So, John, how do you deal with non-compliant, resilient, or difficult families?
Well, it's a lot easier to deal with non-compliant patients than it is to deal with non-compliant families. Families have active processes and they engage in subterfuge for the most part because they may have 5 or 6 individual issues that they have to bring up, and everyone has a need to get it resolved as quickly as possible because they want to be made comfortable, to feel comfortable, and we can't do that. So we have to teach them how to live being uncomfortable, because the goal that they want, by definition, is to cure the identified patient, and they can't achieve that goal. So they're going to be frustrated, and frustration takes various forms. It's going to show up in anger. It's going to show up in resentment. It shows up in quick talk, anger talk. So what you have to be able to do is more than anything else, as the person, you have to understand, the therapist has to understand and be empathic that the fact that what they're going through is extremely difficult. The therapist may be educated, but I guarantee you, for the most part, the family's not educated as to what's going on. Just because the therapist knows what's going to happen or what could happen because they've been through it 50 times or 50 years, whatever. I guarantee you that the family has never been through it like that. So you have to educate everyone. So you have to teach. And I think for the most part, and this is the poorest part of what I do, is document. Write it down, because you're not going to remember in 6 weeks what you discussed. And I think it's extremely important to go back and show patients and patient families how they have changed, how they've gotten better. You set boundaries because boundaries are guidelines. So it's not so much that they have to be firm, but they have to be at least fair enough where we can understand where we're deviating from those boundaries, because there is a right and wrong. And we want to do it the best way that impacts on the best treatment outcomes. And more than anything else, when you have non-compliant patients or families, don't give them ultimatums, because the process is too sophisticated. Say do this or else. That never works. So you have to be patient, and you have to be you have to be ahead of the family and come up with better options to treat their situation, because they're living in fear, and your job is to assuage some of those fears.
Mm-hmm. And John, is it typical for a treatment program to have a family component, or is it atypical?
It's atypical to have it as an organized component. Obviously, that's one of the 5 components that most treatment programs should have. And most treatment programs are going to have 2 of the 3, or 3 of the 4, 3 of the 5. It's hard to find a treatment program that involves some level of medical assistance, individual therapy, group education, and family education. Those would be the 5 components that everyone should recognize as these are essential components to achieve the most reliable outcomes for patients.
Okay. Well, John, thank you very much for today's workshop. And again, viewers, we hope that this will open some eyes and at least open some conversations with your staff, so that you can look at the types of support that you're providing families as they move through this process of moving their patients and their loved ones from being unstable to stable and healthy. So, John, anything in conclusion here?
Yeah, I think so, Kathy. I think what the intent of these information training sessions is to spark an interest in getting more interested in the specifics of what's happening, not just what we've said here. These are outlines. Anything that we've said, any one of these slides could be explored for hours and hours and hours. Hopefully, the intent is not only to educate you, but to improve your treatment protocols so that they're better outcomes for your patients, and that you as a therapist gets better and more stable, because the last thing we need is burnout of our therapists. So I think this is a very sophisticated dynamic where you have interaction with an extremely frustrating group of patients who don't get better with a pill. So keep learning, keep reading, and keep getting better.
All right. Thank you so much. Now, if you're a provider and you have participated in this workshop and you'd like to receive CEU credit, that is available to you. But in order to receive that credit for participating today, we need you to do the following. What we need you to do is write a 2-page reflection paper on how your thinking has changed after watching this digital presentation. Just answer questions like what attitudes have changed, what practices might change within your facility or with you as an individual, and then cite evidence from this presentation throughout your reflection paper. Now, we are doing these workshops in collaboration with St. Louis University and Carissa Vandenberg Clark. She's the assistant professor for family and community medicine at St. Louis U. And you see I have her email listed there. So what we would need you to do is to write that 2-page reflection paper and then email that to Carissa. And in that subject line of that email, please put that this is a CEU request for the presentation, Recovery as a Full Family Experience. Thank you very much for attending today.